The disclosures for guests on this podcast can be found in the show notes.
Hello and welcome to JCO After Hours, the podcast where we sit down with authors from some of the latest articles published in the Journal of Clinical Oncology. I am your host, Dr. Davide Soldaro, medical oncologist at Ospedale San Martino in Genoa, Italy. Today, we are joined by JCO author Dr. Glenwood Goss. He is Professor Emeritus of Medicine at the University of Ottawa, and he is past chair of the Canadian Thoracic Oncology Site Committee and past director of clinical and translational research at Ottawa Hospital Cancer Centre. Today, we will be discussing the article titled Adjuvant Durvalumab in Completely Resected Early-Stage Non-Small Cell Lung Cancer. So thank you for speaking with us, Dr. Goss.
It's a pleasure to be here.
So I just wanted to set a little bit the stage for the articles that we will be discussing. We know that we have been doing a lot of studies implementing immunotherapy in early-stage non-small cell lung cancer. And in particular, there have been some studies in the adjuvant setting. So just wanted to ask you, what was the key uncertainty that you wanted to answer with the trial and why you thought that durvalumab might be a good candidate for this type of population?
So this was a randomized placebo-controlled trial conducted by 290 sites across the world, managed by 10 cooperative groups, of which the Canadian Cancer Trials Group was the lead organization. At the time that we designed the trial and subsequently implemented it, checkpoint inhibitors had been shown to be efficacious in metastatic non-small cell lung cancer. However, it was early on in their development in that setting that we initiated this trial. What we were hoping was that the immune checkpoint inhibitor would improve overall survival in a population where overall survival is the main primary endpoint.
So going back to the population that was included in the trial, just wanted to ask you if you could guide our listeners that maybe are not so keen on managing patients with non-small cell lung cancer as to what was the population, so what was the stage, was there any role of adjuvant chemotherapy included in the trial, and also how long did you plan to deliver durvalumab for?
The eligible population had to have stage 1B tumors greater than 4 centimeters to stage 3A non-small cell lung cancer, who had undergone a complete resection of their tumors. They were then registered and subsequently randomized.
So this patient usually can receive adjuvant chemotherapy in clinical practice. Was this mandated by the trial? Did you allow for centers to opt whether to give chemotherapy or not?
Platinum-based chemotherapy was optional. In our trial, 85% of patients received platinum-based chemotherapy. Following platinum-based chemotherapy, they were randomized 2-1 to durvalumab or placebo, received intravenously every 4 weeks for up to 12 cycles.
Did you exclude patients with activated mutations in EGFR or ALK genes? Was there any molecular selection or was there any other biomarkers that was considered in the trial when you first designed it?
There were no genomic criteria put on the patients. In other words, all patients were eligible for randomization. We included EGFR and ALK mutated non-small cell lung cancer.
And we know that PD-L1 expression might play a role in the efficacy of immune checkpoint inhibitors when given in the metastatic setting. So I was wondering whether the trial did an evaluation of PD-L1, whether this was centralized, and whether you thought that the efficacy of durvalumab in improving disease-free survival, which was the primary endpoint of the trial, might potentially play a role.
So PD-L1 expression was a stratification factor in the trial, and patients were stratified according to whether their tumors expressed a PD-L1 score of 25% or greater, or 1% to 49%, or less than 1%.
So basically, the primary endpoint that you tested, disease-free survival, was in a very specific population because it was patients who had EGFR negative and ALK negative tumors, and also had an expression of PD-L1 higher than 25%, which was the key stratification factor that you just mentioned. So going straight to the results, did you observe any improvement in disease-free survival when looking at this specific population?
There was no improvement in disease-free survival. The hazard ratio was 0.93, and it was not a statistically significant difference between those patients who received durvalumab versus those patients who received placebo.
So basically, this was your primary endpoint, but it's true that the trial design was really hierarchical. So basically, there were other populations that would have been tested whether the primary endpoint was positive. So did you still look at the outcomes with durvalumab in those specific subpopulation? And did you observe any benefit when looking at a broader population, so not selected by PD-L1 expression?
We looked in the entire EGFR and ALK negative patients, in other words, those patients who were wild type for the common mutations of EGFR and for translocations in the ALK gene. The three populations that were examined were the primary population, which, as you've mentioned, was those patients who had a PD-L1 score of 25% or greater, whose tumors were EGFR and ALK. We'll call them wild type. And then the next population was those patients who had a PD-L1 score of 1% or greater, who were EGFR and ALK wild type. And the third population was all patients who had an EGFR and wild type tumor.
And in these other populations, so those with a PD-L1 higher than 1%, or the overall population, even if these are exploratory analysis considering that the primary endpoint was actually negative, did you see any signals for improved outcomes when receiving durvalumab versus placebo?
No, there was no statistically significant improvement in outcome. The hazard ratio for the greater than 1% population was 0.99 as far as I remember, and the hazard ratio for the overall population was 0.89, which were both hazard ratios, the confidence intervals crossed unity.
So basically, what we can say about BR31 is that this is a negative trial. So durvalumab did not really improve outcomes, even when selecting patients for PD-L1, which we thought potentially might be a biomarker of efficacy for this type of drug, also in the early setting, as it is in the metastatic setting. So just to put a little bit the results in context, with the other trials that have tested similar strategy in the adjuvant setting. So we know that there are two trials, one with atezolizumab and the other one with pembrolizumab, that showed different results. So why do you think that there was this difference when comparing the outcomes in a quite similar population treated with similar drugs in the adjuvant settings?
So that's a good question, and that is an important question that needs to be answered. But just to say that the outcomes of the first two trials that you mentioned, which was the atezolizumab trial or the IMpower10 trial and the Pearl trial or KN091 trial, their results were conflicting as well. So in the IMpower10 study, a disease-free survival benefit was seen in the population who had stage 2 to 3A non-small cell lung cancer, and the PD-L1 expression was a biomarker of response. Whereas in the Pearl study, again, in the overall population, they did see an improvement in survival for pembrolizumab over placebo, but there was no correlation with EGFR. Their population whose tumors expressed PD-L1 at 50% or greater, there was no significant difference between the treatment arm, which is with pembrolizumab, and the placebo arm. So coming back to our trial, why are our results different from those two trials? So the first thing is that those results from those trials have changed with time. So at the time they reported their results, their data was not as mature as our data when we reported the results of our trial. So with time, the hazard ratios for the intent to treat populations have got closer together. So they are 0.85 for the atezolizumab study, the IMpower10 study, which is now not statistically significant difference between that or observation. The hazard ratio for the pembrolizumab trial is 0.81, which is still significant. But as you can see, the hazard ratios in the three trials are 0.85, 0.81, and 0.89 in the BR31 trial. So with time, the results have got closer together with updating of their trials. Now, why do we have a negative trial and they have positive trials? The answer is probably in the population. So there are a number of factors at play. The first is that in BR31, all patients had to have had a PET-CT as part of their staging procedure. As you know, PET-CT is the most sensitive of the commonly used diagnostic tests. So it is more likely to pick up asymptomatic metastases with PET-CT than it is with CT, for instance. So in BR31, there was PET-CT scanning. The second issue is that patients could initiate treatment following randomization up to 10 weeks following the receipt of adjuvant chemotherapy. So that was longer than in the other trials. And during that period of time, as can be seen if one looks at the consort diagram in the publication, you can see that there were about 134 patients, I think that figure is correct, about 134 patients who progressed and did not go to randomization after registration. So we filtered out a lot of the bad players. So that is the second issue. The third issue was that the surgical guidelines in our trial were such that patients had to undergo a resection according to the European Thoracic Society guidelines, which are stringent and which 65% of patients actually fulfilled in our trial. Whereas in speaking to the investigators from the other trials, that figure was much lower. And in fact, they had to amend their trials to allow less extensive resection of the tumors. We think that there was more extensive surgery and more diagnosis of the mediastinal lymph node populations. And therefore, the positive nodes were resected, and therefore the patients had a lower tumor burden. Putting that all together, we believe that the tumor burden in BR31 at the time of initiation of treatment was lower than in the other two trials. And that's borne out in the editorial in JCO, which addresses our publication. That point is pointed out, and that is that the control arm in BR31 appears to be better than the control arms in the other two studies. And that may account for the lack of statistical significance in favor of durvalumab versus placebo.
Thanks so much. That was a very clear explanation of why we might potentially see differences in this trial, even considering populations that are supposed to be similar in terms of stage when they are enrolled in the trial, also similar in terms of type of treatments they might have received, and also in mechanism of action, because we know that the PD-L1 inhibition provided by durvalumab is completely similar to the one of atezolizumab. So I think that here patient selection might really play the role. Also, when we think about how immunotherapy really works and now neoantigen presentation and availability of neoantigens might create a stronger immune response and so provide better outcomes when we use these drugs. So starting from this point and knowing that now we have two positive adjuvant trials with the caveats that you discussed previously regarding the different results as the endpoints mature and the follow-up matures, and considering one negative trial that is the BR31, but also considering that we now have different strategies because we also know that these drugs, immune checkpoint inhibitors, have been tested in the perioperative and neoadjuvant setting. Just a little bit of what is your thought as what might be the best way to care for this patient right now. So considering the results of the adjuvant trials and those of the neoadjuvant and perioperative trials, what would be your strategy to best care for this patient in clinical practice?
The point that you have made is very important, and that is that it appears that tumor burden is important in outcome. And there is exploratory results from a number of trials now showing that if you look for minimal residual disease in these patients following resection, that patients who continue to be MRD positive, that is, they have circulating tumor ctDNA, then their prognosis is certainly worse. So we know who most of the bad players are now. They're the ones that still are MRD positive. And what we need to do in prospective trials is that we need to test. First of all, we need to confirm in a prospective manner, in a randomized phase 3 trial, that MRD positivity is prognostic. But there's a lot of data now showing that it is, and however, it needs to be tested properly. If it is positive, if it is a prognostic factor, if MRD positivity denotes poor outcome, then obviously we have to have different strategies for that subgroup of patients. In other words, if we do the MRD analysis after surgery, those that are negative, we could treat in a routine fashion. Now, that has to be defined, what the routine fashion is. But certainly the ones that are MRD positive need better and different treatment, or more intensive treatment, or treatment for longer. But that's the population that needs to be addressed. It looks as though the ones that are MRD, and this is just extrapolation from the small amount of data that we have, it looks as though the ones that are MRD negative probably don't need further treatment, or at least they don't need 12 cycles or 10 to 12 cycles of adjuvant chemotherapy. The Checkmate 816 study suggests that. But of course, we need the properly designed trials, and there are trials designed to address these questions, which are currently ongoing.
And going back to the MRD, did you collect any type of translational data also to provide this type of information? Because as you said, there is some data that is accumulating, but I think that translational evidence that might be provided from a very large phase 3 randomized trial as yours might also add to this conversation that we were having. So do you plan to further analyze these translational biomarkers in the BR31?
So what you're asking me is the subject of another publication, and I don't want to go into it in too much detail, but we did present our MRD analysis at the European Society of Medical Oncology meeting in Berlin this past October. From our study, which is a large randomized study, it would appear that MRD positivity is definitely prognostic. And we also showed that those patients that were MRD positive did benefit from receiving durvalumab. But a cautionary note, these were exploratory analyses. These were not prospective. Although there's a lot of data, they're still exploratory. This was not a prospective evaluation of MRD.
Thanks so much. That was a real insight into the data of the trial, even if it's not really related to the publication in the JCO. So with that, I would like to thank you again for joining us today and discussing your paper.
Thank you very much for having me. It's been a pleasure.
And it's been a pleasure also for us to discuss and share more on your JCO article titled Adjuvant Durvalumab in Completely Resected Early-Stage Non-Small Cell Lung Cancer. If you enjoy our show, please leave us a rating and review, and be sure to come back for another episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.